Good afternoon and welcome. Today's program is Leveling the Playing Field, Understanding the Mental Health Parity and Addiction Equity Act. I'm Julie Miller, Editor-in-Chief of Behavioral Healthcare. Today's program is sponsored by Echo Group. Thank you to our sponsor and to everyone in our audience for giving us your time and attention today. And before we get started, we have a few housekeeping details to review. You'll notice that each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking on the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. You don't have to wait until the end. But if you can't see this area, just go ahead and click on the red Q&A button. To download a copy of today's presentation, please click on the link in the Resources area in the lower left of your screen. If you have any technical issues during the program, please click on the yellow Help button and we'll help you troubleshoot the issue. Finally, you can also tweet during today's webinar using the Twitter widget. Just click on the blue Twitter icon at the bottom of your screen, then click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag BHLiveWebinar. At this time, it's my pleasure to introduce our speaker for today, Suki Norris. As the Senior Knowledge Engineer, Suki is celebrating 20 years with the Echo Group. She has more than 35 years of experience, which includes healthcare law, managed care, and behavioral health. In addition, Suki has extensive experience with Medicaid waivers, meaningful use, and the Excellence in Mental Health Act. Her work includes data analysis, such as analysis of big data in support of clients, and ongoing research. Her knowledge of behavioral health law has been sought by organizations across the country as they address specific needs, such as electronic health record implementation and the challenges of health information exchange. Suki, thanks so much for taking the time to speak with us today. And with that, I'll turn the audience over to you.
Thank you very much, Julie. And thank you all for joining. What we're going to talk about today is the Mental Health Parity Act, for short. The Mental Health Parity Act is really something broader than just Medicaid or commercial insurance. And as we talk about it, much of what I'll say comes from the commercial insurance experience with parity because it just moved into Medicaid officially as of March of this year. What we're going to do today is go over a bit of an introduction. I want to talk about some of the general parity requirements, and then really spend some time on what disparity is, really where the violations of the Parity Act. And then lessons learned. The lessons learned are really based on the 7 or so years we've had to look at how parity has gone on in the various states as they work with commercial insurance. Then a couple more thoughts I have, some questions, and the very last slide and the last couple of things I want to say have to do with sort of further information, places you can go to get information about parity and to get some more information about what I'm talking about today. Parity is defined as the state or condition of being equal, especially regarding status or pay, making it a kind of an easy jump to apply it to insurance. Within insurance, parity laws and regulations are really aimed to eliminate restrictions that health plans may place on mental health and substance use disorder services. And those restrictions are, as we'll talk about, limiting access to those benefits, making them more expensive, making them more restrictive, or limiting them to a place of just non-existence. So a little bit of a history. The Paul-Wellstone Act was the original foundation for the most recent iteration of parity. It was passed in 2008, and while it mentioned Medicaid, its initial focus was on commercial insurance. It was designed to correct discriminatory healthcare practices against both those with mental illness or addiction challenges. Significantly, the law aimed to curb both the financial and non-financial or non-quantitative ways that plans limit access to addiction and mental health care. But its initial focus was on commercial insurance, group health plans. So you all may have seen it in your health plans, not so much in Medicaid work originally, but in the way your health plans were required to address parity. As I said earlier, in 2016, in fact in March of this year, Health and Human Services published the final regulations with respect to parity as it relates to Medicaid managed care organizations, the alternative benefit plans, and CHIP, or the Children's Health Initiative. Again, parity is going, the most recent rule is going to apply to Medicaid individuals who are enrolled in a managed care plan, which will include, which many of you have, a prepaid health plan or a prepaid ambulatory health plan. Now, Medicaid alternative plans are those plans which came out of the Affordable Care Act. That was the definition of the plans that were going to be applied to the additional Medicaid recipients based on the Affordable Care Act expansion of Medicaid. And then finally, you're probably all aware of the Children's Health Insurance Program, or CHIP. As to both the alternate benefit plan and CHIP, it is an absolute application of parity. It is not based on what kind of plan is presented. It doesn't have to be managed care, doesn't have to be any particular kind of plan. Just the very nature of those two situations will require that parity be applied. So, because managed care is really the first precursor of this, I wanted to provide a view of where managed care is, or in fact where it isn't. And because some people are more visual, the next slide will be a list of those states. But here is a view of those states which have Medicaid managed care. Now, all of those states that are not gray have a managed care plan that includes both medical and surgical services as well as mental health, behavioral health, except North Carolina. In North Carolina, it is the managed care plan exclusively speaks to behavioral health services. Here you get a little bit of idea of what is of really how far and how many people this might affect based on just a few numbers. So based on what you saw in that last slide, 86% of states have a Medicaid managed care plan. In those 43 states, 63% of their Medicaid eligible persons or people are actually participating in the managed care plan. The states without managed care are listed there. Of those states, Alaska, Arkansas, Connecticut, and Montana have accepted Medicaid expansion, so really they are part of the Medicaid. They are part of the parity law, not for their Medicaid eligibles, but for the expanded Medicaid eligible population. So they, based on their alternative benefit plan, which has to be given to those folks, will also be part of the parity legislation. So what is parity? Parity really is designed to ensure that the financial requirements and treatment limitations that apply to mental health and substance abuse plans are not more restrictive than those that apply to medical surgical plans. It's important to note that parity isn't designed to force the provision of behavioral health services, but to enforce parity if those services, if that is covered as part of the plan. And you'll see that as indicated. So again, the whole goal of parity is to ensure a leveling of the playing field on a financial and a treatment basis for all covered services that a health plan covers, whether they be medical, surgical, or mental health and substance abuse. So how is parity determined? Well, the first step in determining parity is identifying categories or classifications that will apply both to mental health and substance abuse and to medical surgical coverage. Those classifications, as you see there, are really in 4 major groups: inpatient, outpatient, emergency care, and prescription drugs. Outpatient has 2 subclassifications, that is office visits and outpatient services. And then prescription drugs may be divided into tier coverage. So you can have tier 1, tier 2, and those tiers can be based on cost, efficacy, generic versus brand, or mail order versus pharmacy pickup. Also, please note that one of the requirements of parity is that as you apply your benefits to these particular classifications, you have to be reasonable. It has to be a reasonable classification, and that is something that will get considered. Another thing that is added and was a point of a lot of discussion when the final rule for Medicaid was proposed was the covering of residential services, because residential services have always been a challenge in Medicaid because IMD is not a covered benefit. There is a limited construct for the covering of residential services as compared to those that are covered in medical and surgical areas. So disparity is defined in 3 areas, and 2 are pretty simple to understand and pretty straightforward to find. The first is financial. The next is something called quantitative treatment limitations. And the third, which we'll spend some time on today, are non-quantitative treatment limitations. So financial is simple. It's deductibles, copays, coinsurance, and out-of-pocket expenses. I'd also say that lifetime benefits are part of financial, but as Medicaid has, there really is no Medicaid plan that I've ever seen that has a lifetime benefit because of the nature of the coverage. So I've left that one off, but that is certainly something in commercial that is a key indicator of parity. Qualitative treatment limitations are things that you might think of like restrictions on the frequency or number of treatment sessions, waiting periods for treatment, limits on the number of bed days, things that you really can break into real numbers. You can see them, feel them, identify them, and you can compare them between your medical surgical benefits and your behavioral health benefits. And I want to say again that I said something I said early on. As I talk about parity for Medicaid, please, with your other hat, your private industry hat, remember that these are also the parity rules that commercial insurance has to follow. There are a few differences which I'll talk about, but in general, these are the absolute same rules. So if your own health plan isn't covering them, we'll talk about what you can do, what you might want to do to follow up on that. And then the third disparity is the NQTL, or the non-qualitative treatment limitations. And these are limitations that you're never going to be able to express numerically, but they truly will limit the scope and duration of benefits for treatment. So how do people figure this out? Aside from being a lawyer, I graduated with a degree in mathematics, so I find this really simple and easy, and I'll try and kind of break it down for those of you for whom math is not your was not your favorite subject. The concept of, in order to find a financial disparity, the first thing you're going to do is going to look at 2/3 of the medical surgical benefits in a classification. Remember the classifications we talked about early on: outpatient, inpatient. So we're going to look at what are 2/3 of any requirements, either qualitative or financial, that apply to 2/3 or more of a particular benefit. Once that's found, that means that there has to be parity between those two. That 2/3 limit, that 2/3 benchmark, is the benchmark that says, okay, if 2/3 of the benefit is provided in medical surgical, then the similar benefit in the classification must be provided in the behavioral health world. So in a financial world, how is that done? Sometimes in the past, there were copays that were applied to behavioral health that were not applied to medical surgical. So that's the example you see here. If I have a $5 copay for outpatient behavioral health, then there has to be at least 2/3 copay, or 2/3 of the same classification in medical surgical has to have a $5 copay. If I don't find that, then that copay cannot be applied to the behavioral health. What happens is, once you identify 2/3, so if there are 2/3 of those outpatient classifications are going to have a copay, then it's okay for there to be a copay for your behavioral health. The next question comes, well, what is the amount of that copay? And the way that that's figured out is, if half or more of the benefits have a single copay applied, then that copay can be applied to behavioral health. So if outpatient classification has is 2/3 of the whole thing has copays, and over half the copays have a $5 copay, then that $5 copay can be applied to my behavioral health services. If I don't reach the half or 50% qualification, then I'm going to start combining the various copays until I reach 50%, and I'm allowed to start with the most expensive. So I will just start to collect all of them, and when I hit 50%, then that would be then I can take that requirement, I can create that as my copay. And it would be the predominant level in that 50% that I've collected. Again, it's math and it's a little bit overwhelming, but the idea is, I think, pretty simple. You're not going to have a copay unless 2/3 of the similar classification for medical surgical has a copay. If I know I'm going to have a copay, then I'm going to look at the medical surgical copay, and I'm going to make sure that the numbers are consistent. So if it's $5 for over half, it's $5. If the average of the top 50% is 20, then I can have a $20 copay. So the system is designed to try and create some equality, understanding that it's not a level playing field in either area, perhaps. Well, if that hasn't overwhelmed you, then this next graph might. This is just a flow chart. If you download the C, you'll be able to see it, of how that how you go through identifying whether or not you have a financial disparity. It follows just what I was saying about the step one is there 2/3, and then how do you determine the total amount, and then how do you calculate what that amount should be if in fact you're dealing with 2/3. So the next thing I want to do, now that I've filled your head with math, I'm going to step back and look at NQTLs, which I have called the amorphous disparity, because it really is an amorphous disparity, because you have to see it and understand it to understand what the disparity might be, because it's kind of hidden within the requirements that you're following or the items that you're required to do. And to identify them and to research them, you may be looking at written policies, maybe in the plan benefit design. You're really going to have to look beyond the numbers to be able to identify those items. And they are likely to be the most prevalent disparities that you're going to see as parity is implemented. So I have some examples. The first is medical management standards. If I have two different medical management standards, what do I consider medical necessity? How do I define those items? If they're different between behavioral health and physical and medical surgical, then that's a disparity. You might have to in order to find this, you may actually have to request from the company their written documentation about how they determine how they manage medical decisions, how they do those limit benefits, etc. That might be something you're going to have to see in your plan design, or in the design of the Medicaid plan, or in what your carve-out Medicaid managed care providers are providing. The next is in prescription drug formulary. It can be, if a formulary is if there's larger constraints on the behavioral health formulary than the medical surgical formulary, that's disparity. But you would really need perhaps a psychopharmacologist or someone to understand, is that formulary really different? Are they really applying different standards? Because that's what this is getting at. The formulary is not going to, there are going to be different drugs in the formulary, obviously, but what is the predominant design of the formulary, and is it designed across all services in the same manner, with the same determinations, with the same requirements? Provider network, admission standards, and reimbursement rates. I think this one is probably, from what I've read and what I've seen, one of the most predominant problems that we're having with parity, with mental health parity. And that is that you're not giving the same kind of rates to your behavioral health providers as you are to your doctors or physical therapists or others. So the network is not nearly as expansive as your physical health network. I know in commercial parity, I think this is one of the largest problems that I've seen living in a more rural area. The networks are not as expansive. They are not finding those providers to provide the services. Whether it will be as a similar problem in the Medicaid world is still something we need to see, but it is a real challenge that we're having in identifying why are the network apps is the failure to expand the network based on rates and a different stratus of rates, or just the concept that behavioral health providers feel like they can just charge cash and get paid. The methods for defining usual and customary. Again, if you spent some time looking at how usual and customary is determined, you could see how you might have a difference of opinion. It may be easier to define usual and customary when dealing with a strep throat than dealing with a particular behavioral health diagnosis. Step therapy and fail first. Now, oftentimes step therapy and fail first is applied to pharmacy benefits. In this application, we're really talking about the ability to get mental health services or behavioral services. As an example, you may decide that a person needs intensive outpatient, but the step therapy or the fail first might say, no, I want to see them in partial or less intensive outpatient first. So that you're looking for the client to fail at that level before you're going to put them in a higher level. Again, you're not necessarily going to see the same kind of actions on the side in medical surgical. So how are you going to define the disparity? Well, that's one of the challenges that is faced in determining parity, that you cannot be more restrictive, and this is a place where restrictive could happen. Exclusions based on failure to complete a course of treatment. If you don't have those exclusions, let's say a person doesn't finish their antibiotic, but you're not going to exclude further treatment of that particular disease, whatever it might be. But let's say a person doesn't finish their substance abuse treatment. Well, a lot of health coverages in the past have said, that's it, you're done, you don't get another chance. That's not as you look at parity, you have to make sure that in the classification that the substance abuse treatment occurred, that classification you're treating medical surgical in the exact same way, because if you're not, you cannot have that restriction on those behavioral health services. The network tier design with preferred providers and the like. Again, if you put on different restrictions, you are going to fail at any parity review, and you are going to have to make changes, and there will have to be a corrective action. And then the last is the standards for access of out-of-network providers. Again, it's pretty self-explanatory. If you're not going to get those, if those folks aren't going to get them, if you don't let folks go to out-of-network behavioral health providers, or you pay a lesser percentage of a rate than you do to medical surgical, then you have violated parity rules. Again, for the visual, this is just an example of where the disparities are going to lie, where you're going to see them. And you'll notice the large, that blue area of the graph clearly shows what the percentage of NQTLs are to all other items that show failure on the part of parity. So this thing that is the hardest to define is probably the most important to watch out for. So the next thing I want, as I said, in 2009, parity was first introduced, and it was introduced to commercial payers first. So what are some of the differences as it moves into Medicaid from that original commercial implementation? The first was, in Medicaid, you are going to be applying parity across different service systems, delivery systems. And that is not how you're going to see in commercial insurance. One of the reasons, this is going to occur for multiple reasons. One is that once a person is enrolled in a Medicaid managed care, any services that they get, even fee-for-service services, have to fall into the parity rules. The other reason is that some states still have separate agencies for mental health and substance abuse. So they may have plans that go over those two, that span those. That's going to be different systems. In commercial insurance, it really isn't so likely. So you really now have a challenge of understanding parity from coming at it from multiple directions. but all going to the same comparison between your medical surgical providing benefits and your restrictions, etc., with behavioral health. There's a cost exemption that applied to group health, having to do with what is the extended cost for this. That hasn't been extended to Medicaid. There are other ways that Medicaid manages costs, but the cost exemption doesn't come through. And then this concept of expanding it to the alternative benefit plan and CHIP plans really do create some challenges to the agencies within your state, generally Medicaid departments, that are going to handle those benefits that commercial insurance just doesn't have. That said, we have had an opportunity recently or over time to look at what are the experiences of the implementations of parity. Because think of it this way. When I talk of Medicaid parity, it's clearly at a state level. But so is insurance or commercial parity, because each insurance company is authorized to do business in a state, and the state's insurance departments of insurance are going to oversee that. So states have had experience in reviewing parity, in identifying issues with parity, and approving or not approving parity plans. So that said, there are some similarities that allow us to kind of look at what we've learned. And the first is, and I've said this before, commercial insurance is finding this a lot. Parity does not guarantee coverage, and there is an absolute shortage of behavioral health providers. We all know that there's a shortage of psychiatrists, of children's psychiatrists, but this is also psychologists and MFCCs and marriage and family counselors. In all areas of licensure, there is a shortage across the country of these providers as compared to medical surgical providers. We have seen, just as I talked about before, that there has been reimbursement rates for mental health and substance use that are lower than the similar services in medical surgical. And this is going to depress and has depressed access to services. It's going to directly relate on whether I can fill out my panel if I'm not paying them. And then, as I said earlier, even when there are behavioral health providers, many of them are finding they get more if they just do provide services for cash payments. And then the fourth item is I think really, really, really important. And that is, given the opioid and heroin crisis that the country is facing, there is an absence of real understanding of how parity is going to apply to the various services and the services needed and being designed for those kinds of services. And a few more lessons that the states have found. You are going to be more successful with parity if you have open channels of communication. There are a lot of different parties that have to come to the table. A standardization of materials. Try and make it so if I'm looking at one classification, I can look at the other classification the same way. It's going to help the providers of the insurance as well as the state to understand it. And to that end, you have to create these templates and workbooks. Perhaps use the ones, base this on the ones that have already been developed for the state in approving existing commercial plans. Do market conduct exams and network adequacy assessments early on. How is the market working? What is the network like? And then finally, understand that it's a collaborative process that has to include the various state agencies that have done this before or may be doing it for the first time, and stakeholders. They may be your carve-out managed care providers. They're going to be individuals. They're going to be many of you folks who run the agencies that are going to provide these Medicaid services. That communication has to occur. over the next 18 months, the states have 18 months to develop and get approved their plans that will address parity. So while the rule became final this year, there's another year and a half before parity must apply to all Medicaid managed care and the other two areas. Once implemented, so they're going to have to do the parity using some of the items we just talked about. And then I'm going to suggest that what's going to happen next is there's going to be annual reviews. You're going to have to review parity, the stakeholder group, on an annual basis to ensure continued compliance, especially when you think of NQTLs, because those are the ones that are going to be hidden. You may not see them. They may not jump out at you. You're going to want, especially with carve-out managed care, clear communication of expectations so that carriers understand the expectations, understand policy guides, understand all the kinds of requirements that are on them, and that parity becomes part of their, for want of another term, DNA. That's how they see their benefits. That's how they describe their benefits. That's how they provide their benefits. And then you're going to want routine and targeted managed care entity desk audits. Go in and look at what they're doing and how they're applying the rules, because that's going to be where you're going to see some of the challenges with parity. So a couple more things that are really, I think, important. TRICARE right now does not include parity, and DoD is in the process of applying those benefits and ensuring that the TRICARE benefits are also fall within the parity paradigm. But that's really important with CCBHCs, with other focus on services being provided to this population, and some of those services being very much in the behavioral health area. It's essential that the parity rules get applied as soon as possible, so that there really is an equal concept between medical, surgical, and behavioral health. And the other one is one that maybe not is as aware, but Medicare Part A does not have a parity rule. So Medicare Part A has a 190-day limit on psychiatric hospitalizations, but no such limit out for other inpatient. That would be a violation of parity were it to be in any private plan. But it's not in a private plan, it's in Medicare Part A, and that really needs to be addressed and made part of the parity legislation. And then I just want to reiterate, dealing with how we bring in opioid and heroin services into a parity paradigm is critical, because those services may require things that without parity, behavioral health plans may not be designed to cover. But when you think of residential care, when you think of the classifications for inpatient, for prescriptions, every one of those is going to come to bear on our ability to be responsive to the epidemic. And if we don't bring parity to that, then the kinds of disparity in rules around prescription drugs, as well as outpatient and inpatient services, could really affect the coverage of those services on an ongoing basis. So one of the things that I wanted to cover here too, and that is resources. Now there are a lot of resources that are listed here, but a couple ones I really want to stress. You folks are in an interesting position because many of you run nonprofits, and so you're going to want to work with your states. Those of you in states with Medicaid or other people or other coverages that are part of your clients. You're going to want to work with your states to watch how they implement parity, to ensure that there aren't an NQTL which could occur are treatment plans. Do you have a requirement for treatment plans that's more that is more difficult to meet in behavioral health than in medical surgical? The kinds of things that you are currently very well aware of. Assessments that are required to provide treatment versus a diagnosis provided by a provider. The kinds of things that you are required, that your managed care companies are requiring you to do, that the state might be. Looking at how those get rolled into parity and how they get managed in parity is going to be of critical importance over the next 18 months. Without the stakeholder involvement, without your watching it, the states aren't going to have the same, the state may not have the same required to meet, aren't going to be held to the same standards that you would expect them to be held to and that HHS expects them to be held to. But it's not just that. Whether it's today or in 18 months, every client is responsible, whether you are going to see your behavioral health provider or you need you need an antidepressant and it's not being treated fairly, or your clients in 18 months do. So the question is, where do they go and what do they do to get services, to get some help? The first is, at the very bottom, there's a client portal. HHS has created a client portal where an individual can go to this URL, select their state, and select the coverage they have in their state. And in practice, in theory, it sounds like a really nice idea, but I'm not always sure as I go around the country that every Medicaid recipient knows which of the multitude of programs a state might have they're actually covered by. Because many states have multiple waivers, they've got multiple programs, and me as a consumer, I know I'm getting services, but I don't know necessarily. So you may need to work with your clients to help them understand how to work through the portal. But the portal is really being designed. President Obama created a task force to ensure compliance with parity. It happened that this task force was working while the Medicaid rules came out. In the task force presentation that came out just recently, last month, they spoke specifically about Medicaid and the things to watch out for Medicaid, and some of the things that I've even raised today came from the task force and what the task force has learned in looking at parity across the country as it's been applied. This portal is one of the things that they were tasked to do. And I've been out and I've looked at it from various states and find that it really does work and provide the kind, again, if you know your plan, kind of information that that might be helpful. In addition to what I've listed here, which there are other resources on this page, speak more to some of the supporting documentation for what I've talked about. Also, the legislation, if you're into reading the actual Health and Human Services final rule. But to give you some other ideas so you can see it again, you might want to review it. I also have found, since I published this, a few other things to consider, and I'll be making these available after the presentation. The first thing is actually a document that was written by health law advocates to help you to identify parity violations and talk to you about how to take actions. So what does a parity violation look like? And then who do you talk to? What do you do who do you contact, and then how do you demonstrate that a parity action has occurred. One of the things I'm going to say is that when it's commercial insurance, the Department of Labor, the Department of Insurance are the controlling entities. They're the ones you'd go to in your state or at the federal level. With Medicaid, it's a little not quite as clear. Now, Medicaid, the states could push this to their insurance commissioners, and they may very well do that. But it's not, because we don't know how states are going to finalize their plan, we don't know yet exactly how they're going to do that. And then I found two more documents, and I was joking that it really gives you an idea of audience. The American Psychiatric Association put out a fair insurance coverage document that's very formal and speaks to, it gives you 10 points that explains parity and then tells you who to call. Again, designed for a health plan, but you would imagine, and I would imagine that we'll see these as an outgrowth of the Medicaid parity rules. And it's a very formal, it's written, it's written really at a level of a more sophisticated consumer to define, and defines parity and tells you the kinds of things to look for. Many of the things it's going to say have to do with the NQTLs or things that you're going to be real familiar with, like comparing copays and out-of-network. And that was put out by the American Psychiatric Association. Now, the American Psychological Association came out with a much more friendly document that also describes parity, but it's really written at a level that's more, I think, conducive for a client or consumer, because it really does speak to kind of break it out as what does the law do, a lot like the very first document I talked about, but designed in a more friendly, more expansive way to help individuals identify parity issues and then help them know what to do about it. Kind of safe, simple language, a simple presentation. In each instance, the end result of this is to go to your state insurance commission or the National Labor Council. Again, remember that while these are the methods by which you would identify a violation and tell somebody about a violation, going back to what I originally said is this really is still applying to the commercial insurance or group health insurance parity and should be used as examples for how your state implements parity, but wouldn't be the final product. And I guess the final thing I want to say is if when you looked at the state map and the list of things, you thought, well, I'm safe because my state's not on there, whether it be for Affordable Care Act, expanded Medicaid, or managed care, I'm going to guess that all 50 states, I know that all 50 states have CHIP programs. So even if you're not on there because of managed care, and you're not on there because of expanded Medicaid, you still are going to have to work with your state because your CHIP program is going to go through the same, if it hasn't already, analysis for parity between healthcare, between medical, surgical, and behavioral health. And more to the point, because many of those CHIP programs are broken into multiple levels, you're going to have to look at each level, so you will get a multiple analysis done at the gold and silver and bronze, or however your state has identified those. So that pretty much concludes the content, but I am very happy and looking forward to answering questions. So let me get to the slide that says questions like no other slide can, and I will turn it back to Julie.
Great. Suki, thank you so much. This was a great presentation, and we have had a lot of questions come in, but remember, you can use that Q&A widget below the slides on your screen to submit a question. So someone in our audience asks, Can a provider demand that a health plan provide its parity compliance information or allow an external audit?
They can't demand an external audit, but they can import they can report the absence of parity to, again, their state insurance council or the federal, generally the Department of Labor. So they can report those violations for non-Medicaid today, and the provider is entitled to report it just as much as a consumer is entitled to report it.
Great, and I know we had mentioned network adequacy. So someone in our audience is asking, is the availability of providers truly a shortage, or is it an indication that providers are unwilling to work with Medicaid reimbursements?
Well, I don't know yet because we don't know from Medicaid reimbursement, although I could guess, but that's not my role, I think. Right now what we're seeing is a shortage in the commercial insurance. So here's my guess, and I think it's reasonable to base it on. If I can't get providers to take commercial rates, I am not going to get them to take Medicaid rates. The difference is that at least within Medicaid, I may within my state have some sort of nonprofit setup that does cover behavioral health for Medicaid recipients. And I may be able to work within that existing design to at least get providers in that area. But I know, I'm talking about where I live, frankly, but I know unless you're in urban, suburban areas where there's a plethora of providers so that they are going to take it, you are probably dealing with a shortage of behavioral health providers across all licensure and an absolute shortage. And this, I remember, I did some work in California and San Diego in managed care. You couldn't get a child psychiatrist even in an urban area without really looking at your rates and trying to do something because they just weren't available. So I think the answer, going back to it, is I don't know what the problem is going to be in Medicaid, but I know that there's an absolute problem that is ongoing with commercial insurance, and there has not been a solution found for it as of yet.
And in a similar question, someone in our audience wants to know how parity might create pressure on payers to open up their networks. Is there some type of a measure, like a ratio of members to beds, that could be used to demonstrate parity or lack of parity? No, there should be, but there isn't. I will say that this was one of the major items that came out of the task force, so I can see in some expanded rulemaking that there could be some discussion about this. Again, the challenge is going to be within Medicaid, the Medicaid world, how those networks are developed. And who, if it's a carve-out, who the managed care entity sees as part of their network, or who, if the state is running it, they see as part of their network. But it was enough of an issue of the stakeholders that reported back to the task force that I would expect to see more information coming out on this development of networks. So it's still a wait and see because it's not specifically a parity issue, but it is a tangential parity issue. Mm-hmm. And you mentioned the Federal Parity Task Force, the final report from October. That's a very dense report. There's so much in it. Are there one or two quick takeaways that you can offer to our audience who might be reading that report? Much of my presentation, no. I would say that the takeaways that resonated with me were some states are doing this very well. And there's actually another reference in the list of references. Some states really have figured out how to do this, are working with their insurance companies. These are states with large urban areas, for the most part, I will say. But the network parity, the parity of the provider panel, whether that's a parity issue, as I stated before, or just a realistic issue, is really something. So that what is happening is, in practice, you're not getting the same content of services because there just isn't a way to provide them.
I think that the task force proposal and sort of what I took out of it was that. The other thing I'm going to say is that one of the things the task force has done is they've presented a series of Q&As. One is referenced in my list. Each one deals with sort of a separate topic. So if you're very interested, let's say, in this concept of prescription drugs as relates to opioid and heroin epidemic, there is a Q&A that focuses a lot on that information. So there are those. They've also presented those Q&As to sort of get at some of the other data to allow folks to get at really what interests them versus sort of a general review of what's going on with the task force.
Great. Now, talking about that Q&A, particularly for the drugs that are related to substance use disorders, do you know, is it a requirement, a parity requirement, that a health plan cover all three of the drugs that are typically used? Do they have to cover those? Do they all have to be on formulary, buprenorphine, methadone, naltrexone?
I don't know if they have to be. I think they should be. I think they should be and that there are, this is me speaking, I'm just speaking as me, but I think that they should be, and that they are allowed to put some restrictions on use that would be okay with parity, the same way that you're not going to give nitrogen, I think it's nitrogen, to somebody who doesn't have heart problems. So, because it could be dangerous otherwise. So, and you're going to limit access the same way painkillers are going to have to be limited, because otherwise you're going to create a greater problem. So yes, I think that there are health plans that I've seen based on the Q&As that cover those. I haven't always seen methadone, but the other drugs, yes. But I do believe that they are allowed to have rules that are reasonable as to when they can be prescribed, and it's going to be at that reasonable thing that you can't restrain access to those drugs because frankly you're not supportive of that population. You have to have whatever the precursors are, whatever the formulary requirements have to be logical, objectively logical for the drugs that you're prescribing. Absent the objective logical, I think that they would be in violation of parity and they would have to provide those drugs. Certainly something the state Medicaid folks are going to have to look at.
Mm-hmm. Now, in your opinion, do you have a sense for how health plans are defending their coverage denials? I mean, are they saying that it's impossible to compare apples to apples, or what is their reason when they deny coverage?
When they deny coverage, I mean for a particular service?
Yes.
Trying to be objective. I'm not sure I have an objective answer.
Is it often tied to medical necessity?
It's tied to medical necessity, and when I see the biggest problems, what I see is that a person is determining medical necessity that doesn't have a specialty that's akin to what's being denied. So an orthopedic is going to deny a drug for ADHD, or you get the idea that they're not. That the health plans, the way they're doing this, which I think violates parity in some real ways, because unless they're doing the same unless health plans are doing the very same thing to your medical surgical patients, which I don't think they are, but they're not using licensure that's appropriate for making the determinations that need to be made.
Okay, let's see if we can fit in one more real quick question before we wrap up. Are there financial penalties for insurers that violate parity?
Yes, but not nearly enough. That's another issue that HHS is looking at. I think it's in the task force report. There have got to be stronger penalties, because oftentimes the decision can easily be made that the cost in violation is less than the cost of meeting the needs. Originally, it was thought that the health plan report cards would somehow make this all right, but that's not working. There are penalties, but they need to be much greater. and much more. They have to be greater than. They have to really be a painful penalty to make that to change that behavior.
Very good. Unfortunately, that is all the time that we have for questions, but I want to thank Suki Norris again for an excellent presentation. I would also like to thank our sponsor, Echo Group, for making today's program possible. Finally, thank you to everyone in our audience for participating today. We hope you'll join us again in the future for another behavioral healthcare webinar. This concludes today's presentation.